It's been an honor to participate with people like Dr. Talaj, Lydia, and John Dionisio, which you've heard earlier, in working with both the patients, because we're small business owners embedded in the community, and obviously with all these providers. First of all, I think I'm very usually like to approach things from a positive perspective. I mean, we have evolved from paper charts, and so, sometimes we forget what the journey has been. But obviously now it's the present, like my therapist says, and you gotta work from here onward. So, for me, one of the issues that I feel that has not evolved enough is the spaces where the physicians work in, because I hear, and obviously the patients are at the center of everything that we do, but when you're looking at a room like this where we have administrators and multiple technologies that manage dashboards and Tableau and all these resources that are amazing to look at things from the 30,000 feet height, the physician which lives inside the EMR, I don't think that, and similarly for the patient, we haven't looked at a way for them to have access to information in the spaces where they live. And so obviously, we at SOMOS work on risk scoring and coding and all these things, and there's so many challenges interacting with what payers want from us, what the pharmacies want, what, all these myriads of systems and people making requests, don't even talk about faxes, and how do we manage that, which are all a ton of external systems, to the place where the doctor lives. And that's what I tell my staff, which I don't see patients anymore. They're sending me messages through Epic, and I feel at the other end of the spectrum where I'm like, you have to actually text me to let me know I need to log into Epic, because I don't live in Epic. While when you're communicating with the doctors that are managing patients, that's where they are, and so you should use that as the core, because lucky enough, even though my team is community-based, we, through meaningful use, et cetera, we're able to have access to Epic as an EMR, and it's amazing, which, talking about integration, allows us to connect. Now that many of the hospitals around us use Epic also, we have a ton of access that maybe many other of the SOMOS providers and other community providers don't have. But coming back to the topic, I think it's, first of all, understanding that the EMRs have not evolved enough in that space of direct patient care. Because we need, and haven't really supported us in the skill set that we're requiring from a physician. Before it was a prescription pad, a pen, and your stethoscope and your blood pressure cuff, and now it's just all these requirements, even for the payment model. We're talking about value-based, and so, your payment is gonna be even, most of our contracts are capitated, but 30 or 40% of our revenue has to do with making sure that we're submitting supplemental data, that we are risk coding the patients appropriately, and so on. So to summarize, for me, the evolution of the EHR, which is the predominant space in which the doctors live, has not been up to par with all the other integrations that we see. You still have these hot buttons that people need to, so it's technically or theoretically, there has been integration, but when you look at it from the end user, we still perceive that we have to connect into multiple spaces to have that key information that we need for decision making. I just finished an AI course on MIT because I felt that there was just so much stuff going on and I needed to take a time out to sort of understand this. And again, it's the same thing. All things are going on. And in the meantime, we're still as providers of care, direct patient care providers, which for me is much bigger than just the clinicians, have not been empowered enough to be able to have that key information exactly when we need it, to be impactful and to align with our payment model. We're talking about faxes, and I'll end with this. Why are providers still using faxes? Because we're not considering that we are also, I don't think that there's the empathy with the clinician that still 30% of our providers are within an age range that may not necessarily be that technically savvy. So yes, we know that they're the younger ones and the nephews and cousins of our previous panelists that don't want to see it, that don't know what a fax is, but many of our doctors, particularly at SOMOS, are in their 60s or 70s and have not had the time to adapt to the evolution of technology.
Yeah.
Well, definitely for the SOMOS providers, we're lucky enough that we're predominantly minority and recent immigrants. So I think, and care extends beyond the actual interaction with the physician. So it's not only because we're independent doctors, because we're embedded in the community, because we're there for many years, we end up developing, similar to what Sean was saying, this sense of community. We're hiring from the areas surrounding us, and that has a ton of challenges, but at the end of the day, the patient does feel that the medical practice is a place, a resource that will support them in all this paperwork, in navigating the system, which is so complex. We end up seeing electric bills and gas bills and bank statements and a ton of stuff that it's surprising how they don't even sort through their mail. They sort of show up and everything looks like a hospital bill or a medical report. And our staff in general is very open to supporting them in that process. And obviously that extends to trying to obtain services for them, DME and everything else that is part of that longitudinal transition that the patient has. We take care of these communities of patients for, I've been in practice for 30 years, so I've seen my patients evolve, hopefully not develop that many complications, but since I don't have a God complex, I know that eventually things are gonna happen, even if they receive the best care possible. But cultural competency extends beyond just language. Obviously, it's about understanding their diet, making sure that we can engage them in what we know that typically is what our families eat, and the relationship with the family, with the child. We understand that there are HIPAA laws, but I can't really tell a daughter that brings the mom every day, even though there's a law there, and we're trying to make sure that we're complying with it, but we understand that you've been here all the time and that you're the facilitator for care. So there's just so many layers to cultural competency, and lucky enough I think we have it innately because we're a minority, most of our doctors, but there's a ton that needs to be trained and educated to not only our staff, but to the people that interact with us. It's like I said, it's pharmacy, it's all these services that surround and that support us in providing the care. Talking about sustainability and communication, I feel, and this, I'd be speaking for providers as well as patients. Yes, we have become closer, but there is a perception that, particularly from payers and from regulators, the amount of the communication is not equitable in the sense they want what they need from the provider and from the end user that is the patient, but when it's time for the patient to access a service and to communicate effectively with somebody that can resolve, there's still a huge Mount Everest, similar to what the commissioner said. And it's the same with patients, with providers and their staff. So for it to be sustainable, we are looking at, you were talking about, the budget, but less than 10% of that is devoted to independent to the provision of ambulatory services provided by independent clinicians or doctors in the community. So I think that for this to be sustainable, all stakeholders need to be taken into account, and everybody has to work towards trying to obtain information in a much more streamlined fashion. I think the commissioner was mentioning about access to websites and access to literature and education. Well, similarly, there's just so many hurdles and so many manual processes that need to occur for somebody to obtain a service that I don't know how communication can be sustainable if there is no somebody looking at it from the perspective of obviously the patient and the providers of care that are not from larger institutions that can afford even having that inefficiency of multiple staff members, of not updating their technology, and so on. So, you know, particularly both at SOMOS and at my practice level, we have been able to do incredible or achieve incredible connections, and in trying to address you know, food insecurities, housing, on behavioral health. Obviously, I take from this meeting that we definitely need to highlight a little more the aspect of patients with disabilities. But I think that is where I believe that there needs to be a little more attention, because again, as an administrative, somebody who works in administration, I see the amazing you know, progress that has been at that level, but not on the provider side and not at the patient's side, and particularly authorizations, you know, communications with hospitals, you know, pharmacies. You know, we're talking, for example, you know, we're in the quality world, so you have, and in value-based, and so you have providers that are still getting spreadsheets that are not really sorted in a way that we can prioritize. And you have people that have multiple gaps in care and multiple issues that you need to address, but honestly, we get lists that are sorted in alphabetical order. So if you don't have a patient, if you don't have a staff that knows how to sort an Excel sheet and knows how to use pivot tables, and we haven't been able to use one of these living in multiple spaces, like I said, and now I have to, you know, log into the quality app of any of the payers. I don't want to signal anyone out. It's just undoable. So, you know, coming back to that, but I mean, it goes, I mentioned gaps in care and risk coding and all this other stuff, but it's really just doing medication adherence, for example, which is triple or quadruple weighted in many of the quality incentives. And it's, you know, the metric is satisfied once the patient picks up the prescription. How do we integrate to the pharmacist system so that I get a notification and I don't need to wait 30 minutes on a call? And even if I'm getting paid $20, I mean, and I pay one of my medical assistants $22 an hour, you know, I know math, and I'm saying, you know, while I want to do well, and while actually my practices and at SOMOS we do very well with quality, but it's just so cumbersome to satisfy all these requirements. I think the commissioner was talking about, you know, accessibility. Well, many of our providers have modified little apartments at, you know, main floors of a building to be able to set up their practices. We're not big hospitals that actually have tons of regulations on how the setup needs to be so that they can get a CO. So, you know, we want to serve our community, and we retrofit an apartment to be able to take care of patients and have to invest in, you know, these lifts and when we can. But, you know, I think that there needs to be that sensibility that, you know, the payment model has to include, and actually during this RIP, there was some capital restructuring grants that less than 5% of providers in the community got. And to be fair, many of the funds that were given, still these are, you know, have not been invested in what the intention was. So I think for sustainability, there needs to be a significant consideration of where the care is being provided, where do we want that care to be provided, and how are we empowering those people to fulfill the needs of the community.